Hello, everyone. I'm Vanessa Cartagena, Meetings and Events Associate at America's Essential Hospitals. Thank you for joining us today and welcome to today's webinar, COVID-19, Homelessness and Housing Resources. Before we start, I want to recommend you use the dial-in number displayed on your screen to listen to today's presentation. Because COVID-19 is causing high internet usage, you might experience interruptions if you try to stream the audio portion of this webinar on your computer. So to ensure a trouble-free experience, we recommend you use the dial-in number for audio as you watch the presentation on your device. Also, like many of you, all of us here are working remotely, so please bear with us as we adjust to the challenges of producing a webinar from multiple locations. I want to take a moment to point out the webinar section of our website at essentialhospitals.org. You'll find upcoming and recorded webinars under the Education tab. Once there, look for the webinars link in the menu just under the photo. As a member, you have full access to the rich library of recorded webinars on our site. Today's slide deck and webinar recording will also be available to members on our webinar homepage by tomorrow. Although your line is currently muted, we can open it if you have a question for our presenters during the Q&A portion of today's call. If you want to ask a question, please use the Raise Your Hand feature at the bottom of your participant panel. We will unmute your line and announce you by name. Now, I am very pleased to introduce today's speakers we have today. They are Jennifer Stevens, Principal Researcher from America's Essential Hospitals, Mary Ellen Guinan, Principal Policy Analyst from America's Essential Hospitals, and Margot Crucial, Professor of Medicine, Director of UCSF Center for Vulnerable Populations, Director of UCSF Benioff Homelessness and Housing Initiative, University of California, San Francisco, and Zuckerberg San Francisco General Hospital and Trauma Center. Now I will turn the call over to Jennifer, who will kick off our presentation today.
Thank you, Vanessa. Next slide. I have to start with two simple words. Thank you. It's two small words that we can't say enough. We need to thank you and everyone in your hospital for all of the dedicated work and time that you're putting into fighting this pandemic. I would like you to know that America's Essential Hospitals is here behind you and that we're here together. We're going to work to make sure that you have all that you need to protect the communities that you serve. Thank you for your sacrifice. Next slide. One of the ways in which we're here for you is by providing resources specific to essential hospitals. Next slide. You'll see resources that you're used to seeing from our existing channels. For example, our federal and state newsline articles, our latest from Action, which provides a summary of our legislative and policy work, and finally, our action alerts, those just-in-time immediate calls to action. There are some new channels that you may have noticed that have come up. We have our COVID-19 updates. You'll see updates including CMS calls to attend and weekly reports on what's going on federal and state policy updates, as well as among our hospitals. In addition, we have our COVID-19 webinar series where you can join us every week on Wednesdays at 2 p.m. to discuss a topic of pertinence to our essential hospitals. Next slide. Additional resources exist on our homepage. To get to these resources, please go to essentialhospitals.org. From there, click the bar in the center of the page for COVID-19 updates and resources. Next slide, please. After you click that link, you'll see this screen. As you can see, there's a wealth of federal agency resources on a number of topics, including telehealth, infection control, substance use, and privacy. To the right of this page, you'll find a link to see member-to-member resources. Next slide, please. Our members are encouraged to submit their own resources as well as look at the resources of fellow members. Again, you must be logged into our website with your organization's email address to access and submit the resources here. Resources discussed today are also included on this webpage. Next slide. Today, we're going to hear from Mary Ellen, and she'll provide us an update on COVID-19 as of today and where our hospitals stand. She will then talk about the federal guidance that exists for homeless. And then we'll transition to have Dr. Margot Kuchel speak about Essential Hospitals' response, specifically in California. We'll conclude with a lengthy discussion and questions and answers from the group. Next slide, please. I'm pleased to transition the presentation today to Mary Ellen Guinan. Mary Ellen, take it away.
Great, thanks, Jennifer. If we can have the next slide, that would be great. So hi, everyone. Wanted to give a situational update on where it stands now in terms of COVID and the pandemic that we're facing. As you are well aware, the case count nationwide continues to rise with over 374,000 total cases being reported as of today in the United States, with more than 12,000 deaths alone. New York itself has seen 122,000 positive cases and more than 4,100 deaths. Where we stand right now is that 42 states, as well as Washington, D.C., Guam, and Puerto Rico, have issued stay-at-home orders encouraging isolation measures to prevent the spread of this virus. In total, that brings about 95% of the U.S. population. We're talking about over 306 million people under some form of lockdown currently. And looking at the hotspots that we have right now, they include New York, particularly New York City and the metro area, Louisiana, New Orleans specifically, and Michigan. And we're looking at Detroit as a hotspot in that state. There are other areas that we're seeing as emerging hotspots, and they would include Colorado, Pennsylvania, and Washington, D.C. Next slide, please. So much has been said about certain groups being at greater risk for contracting this virus and becoming more seriously ill from the virus itself, specifically those who are over age 65 and those with underlying medical conditions such as heart, liver, and kidney disease, as well as those who are immunocompromised. As this public health emergency has progressed, health officials have also flagged other at-risk populations, including, and the topic of this webinar, people who are experiencing homelessness. For people living without homes, this virus is a serious threat. Homeless populations have a high rate of poorly treated chronic illnesses, putting them at greater risk of severe COVID-19 infection. Further, from what we know about COVID-19, the virus is spread through droplet transmission. In other words, effective infection control measures include sanitizing surfaces and maintaining a distance between people to contain the virus. As you can guess, these precautions are not always practical for homeless individuals who often lack access to soap and hot water, as well as staying in crowded shelters. Transmissible diseases can spread quickly among those who are sleeping in close-quartered shelters, as well as those in outdoor encampments that may not have access to hygiene facilities. Next slide, please. This topic is of great importance to essential hospitals, as homelessness and housing instability are among the social determinants of health that essential hospitals work tirelessly to mitigate in the communities they serve day in and day out. From the data and our surveying of members, approximately 360,000 individuals are homeless in the communities essential hospitals serve. And I'll also add, in terms of food insecurity, 10 million people have limited access to healthy food, yet another social determinant that our hospitals are facing and tackling. We have seen throughout our membership that by joining efforts with community partners, such as homeless shelters and food pantries, A network of social services can be built in a particular county or across a region, and with the essential hospital as the center of that social service network. Through their outreach into the community and partnering with these service providers, essential hospitals truly address the complex needs both clinically and socially that often drive health outcomes in their patient populations. In terms of the COVID-19 response, I wanted to take a moment to speak specifically about shelters and the guidance that has been put out in terms of shelters, but wanted to preface that by saying this really has been a pandemic that has required shelters in particular to take on new roles and in quick fashion. For example, practicing heightened levels of infection control, administering screening at entry points into the shelter, or even redesigning locations to promote social distancing, such as rearranging bed patterns. And this is all while safeguarding the shelter's volunteers and workers from the virus themselves. Next slide, please. So with this in mind, the CDC has issued particular guidance, and if we can go to the next slide, in terms of key actions that local and state health departments, homelessness service systems, housing authorities, emergency planners, healthcare facilities, and homeless outreach services can take to protect people experiencing homelessness from the spread of COVID-19. On the slide, you'll see links to two guidance documents, one directed at homeless service providers and one for people who are experiencing unsheltered homelessness. That would include encampments. Both guidance documents can be found on our resource page, which was referenced earlier in the presentation. And I'll just take a moment to highlight a couple points made in the guidance, which is broken down into essentially three stages: the planning stage before an outbreak, the action stage during the outbreak, and then the follow-up stage when the spread has slowed or been contained. Across the board, the guidance really points to partnerships being key, and I think our speaker later in the presentation will also acknowledge that partnerships really are key. Hospitals and healthcare facilities should ensure that they are involved in the planning and the logistics, in particular for the safe discharge of COVID-19 patients to a designated location if that patient does not require hospitalization, but they lack housing. The CDC in these guidance documents address how a local surge may require jurisdictions to establish isolation sites or quarantine sites. These are intended for patients who don't necessarily require medical care, and they are established in non-traditional environments such as a converted hotel or perhaps a mobile field medical unit. These isolation sites can be used for people with COVID-19 who are currently experiencing homelessness but cannot be discharged, or it would not be ideal for them to be discharged to a congregate setting. There's also guidance about encampments. Those are the unsheltered homeless, and specifically about whether or not to clear those encampments. And the guidance has been fairly clear, and guidance from HUD as well in terms of not clearing those encampments at this point in time. I'll also note particular interest to the community served by essential hospitals. The guidance references behavioral health teams being involved in the planning for these isolation and quarantine sites. And this is really to ensure a continued access to support people with substance use or mental health disorders that are also going through the isolation or quarantine measures that are in place. Next slide, please. As I noted previously, shelters are really taking on a new role in terms of screening upon entry. And the CDC has recently posted a screening tool for shelters to use as part of their intake and triage process. At this time, the CDC does not recommend to screen incoming guests using laboratory tests, unless directed to do so by your local health authorities. I know that this is something that our speaker may address later on in the presentation in terms of the effectiveness of screening in the absence of lab tests that could confirm the presence of the virus. But I will leave that topic for a little bit later. Next slide. The CDC also provides a helpful list of frequently asked questions on their website, specifically related to people experiencing homelessness and service providers. For example, should a homeless shelter close? The answer is no. Shelters serve a critical function in our communities, and they should stay open. Or, as referenced before, questions about clearing encampments. Next slide. I also wanted to quickly address other agencies that are involved in work to respond to and address the needs of the homeless population during this pandemic. Specifically, the Federal Emergency Management Agency, or FEMA, is coordinating the federal response to COVID-19 along with HHS and the White House Coronavirus Task Force. This is to ensure state and local governments receive the support they need, including supplies. FEMA recently released FAQs on non-congregate sheltering. This is a community-based response that can benefit many populations, including people experiencing homelessness. Specifically, the FAQ addresses who is the target population for non-congregate sheltering and the various forms that non-congregate sheltering FEMA will support. For instance, alternate case sites and temporary hospitals are not considered non-congregate sheltering supported by FEMA. And just to give a quick state snapshot, and I know our speaker will be addressing the actions being taken in California, and I just wanted to flag that last week California did become the first in the U.S. to receive approval from FEMA to provide safe isolation capacity for a specific population, that being individuals experiencing homelessness. This statewide effort is dubbed Project Roomkey, and it will specifically target hotels and motels in counties with large homeless populations that also have a significant number of COVID cases. FEMA will, under this program, reimburse the state for up to 75% of the cost, which will include hotel and motel rooms, as well as meals and security custodial services that go along with that housing. I will note that this programming and the reimbursement does not include case management and mental health counseling, which is of course, important for the population served by essential hospitals. The purpose of the isolation units is really to address critical public health purposes, that being to prioritize individuals who are experiencing homelessness, who are asymptomatic but at high risk, or to provide isolation capacity for those experiencing homelessness but may be exposed to COVID-19 but do not require hospitalization, or finally providing isolation capacity for those experiencing homelessness who are COVID positive but again don't need hospitalization. Often without these types of isolation units, their only choice is to return to a congregate shelter setting or back to an encampment. And finally, talking about the Department of Housing and Urban Development, HUD, I wanted to make note of the work of HUD and in particular flag for folks on the line their outreach to service providers and others through a weekly office hours that they hold every Friday from 2:30 to 4 p.m. Eastern Standard Time. There is a call scheduled this Friday, and we will link to how you can register for that call in the slides from today's presentation when they're posted. I'll also note that HUD has developed its own series of resources, including guidance to support continuums of care and homelessness service providers. And if you go to HUD's exchange online, you will see a system-wide approach that they have flagged that has been developed for the state of California. This is one that our next presenter is well aware of, given her role in designing and this specific protocol, which includes approaches for how to respond to individuals experiencing homelessness in this crisis. Next slide. So with that, I will turn it over to Jennifer Stevens to introduce our exciting panelists. Jennifer?
Mary Ellen, thank you so much for providing that detailed summary on the federal guidance. I'm very excited to have Dr. Margaret Kuchel present next, as Mary Ellen has prefaced. She has helped design the policies and practices for the entire state of California and is well versed in serving vulnerable populations, given her role as director of the UCSS Center for Vulnerable Populations, as well as the director for the Benioff Homeless and Housing Initiative. Dr. Kuchel.
Thank you so much, and thank you all for being here. Next slide, please. Next slide. So just very briefly, I'm a practicing physician at San Francisco General and have been since the mid-90s, and I direct the Center for Vulnerable Populations and the Benioff Homelessness and Housing Initiative. I just want to make you briefly aware of this new initiative because hoping it can serve as a resource for the America Essential Hospitals. It is a research and policy center where we are focusing on homelessness, health, and housing, particularly at the intersection of health and the health systems with homeless populations. Next slide. As we've talked about, people experiencing homelessness have both an increased chance of acquiring COVID-19 because of congregate settings, crowding, the need to come together for food and other services, as well as an increased chance of severe consequences of the disease, both because this is an aging population. Right now, among single homeless adults, it's estimated that half are 50 and older, and we've documented that homeless adults in their 50s and 60s have underlying health problems similar to those in their 70s and 80s in the general population, which raises our concern that they could be disproportionately impacted by severe consequences, as well as an overall high prevalence of underlying conditions, particularly heart and lung conditions that place people at increased risk of severe consequences. Next slide. I just want to give you a visual of what many shelters look like. When we think about the guidance of having people keep 6 feet apart from one another, one can see how impossible that is in settings like shelters, where people not only have close sleeping quarters, communal meals, share bathrooms and laundry facilities. Most shelters have limited hours of operation so that during the day they send people out. And shelters are facing an unprecedented lack of really basic supplies like cleaning supplies and other measures needed for basic sanitation. Next slide. Those in unsheltered settings face serious threats as well. People who are in unsheltered settings often sleep in close proximity to one another, but also are forced to share personal items, which may be a route of spread. Without intervention, they lack access to basic safety and hygiene necessities. And I want to point out that both sheltered and unsheltered populations generally have depended on social spaces like libraries, fast food restaurants, many of which may now be closed because of shelter-in-place ordinances. But even so, they offer opportunities for people to recongregate and therefore potentially spread infection from one to the other. Next slide. I want to highlight the potential impact on safety net hospitals. Obviously, the impact of COVID-19 is well known, but I want to impact the particular nexus of homelessness and safety net hospitals. Safety net hospitals care for the disproportionate share of people experiencing homelessness in the country. And this population, as I've highlighted, may present very high acuity patients requiring intensive care or hospitalization. what is well documented in this population is, even more so than the general population, they may lack advanced care planning, they may have limited surrogate decision makers or high likelihood of being, as we say, unbefriended, and have a much higher proportion of comorbid mental health and substance use conditions. We also want to highlight that without intervention, we face the possibility of, just when our hospitals are facing concerns about overcrowding and lack of access to beds, that these hospitals may be required to admit people who do not meet typical admission criteria, including people under investigation or people with mild infection, because these patients, the choice would otherwise be to discharge them to congregate facilities, which is not acceptable. Once people are known to be infected and are admitted, America's essential hospitals will face additional difficulty with safe discharges, leading to prolonged hospitalizations. In addition, emergency departments, as they face crowding, may have a difficult time discharging people because, for instance, if you have someone under investigation, even if their symptoms don't require hospitalization, may need to wait for a turnaround for a negative test in order to send them out. Next slide. I want to just briefly go over these screening protocols that we developed for the state of California. These are available on HUD Exchange, on the State of California Department of Public Health website. I will say that the caveat was that we developed these a few weeks ago with certain assumptions. The assumptions we developed them with was that we would have, as we continue to have in California, limited testing supplies, and that we would be able to make private spaces like hotels available, but not available to everyone experiencing homelessness. Next slide. The first part of any of these protocols, and anyone trying to develop planning for this, is the absolute necessity of coordination. None of this will work without the coordination of the healthcare sector, particularly the safety net healthcare sector and local public health departments, with the homeless services sector. Neither can really act appropriately without one another. This program will also call for vigorous governmental response in terms of acquiring the resources to develop isolation and quarantine facilities and to move quickly. I would like to argue that safety net hospitals have a strong self-interest, not only in the interest of protecting their patients, which is, of course, top of mind, but also in protecting themselves, to partner in these efforts to advance these policies. In order for this to work, we need coordination. We need the availability of isolation and quarantine units. Things like hotel rooms, trailers, RVs, dormitories have been suggested for this possibility. We need hospitals to ensure that they are screening for homelessness. This sounds very fundamental, but is often forgotten. And at the end of the webinar, I presented just some basic screening tools that could be used. As I said, hospitals have a self-interest in helping to stand these up. And in order for this to work, there needs to be a coordinating agency to help the parts move together, and that this usually is best done by someone with medical training. And in some places, this is where hospitals have made available nurses, for instance, who are well qualified to do this. Next slide. This is our basic screening protocol, and I'm sorry if it's a little blurry on your screen, but I just want to walk you through particularly the left side of the protocol, which suggests what patients in medical care needs to do. This takes into account that people in medical care will be both screened for homelessness and screened for COVID. It's impossible to do this without both of those. We know that for some people that will mean hospitals admitting patients who are COVID infected, recognizing that they're homeless, being ready to discharge them when they no longer require hospitalizations, but when they may still be infectious. Or people presenting, for instance, to the emergency department and never requiring hospitalization, but are recognized as either potentially infected or a person under investigation or infected. we recommend that for people who are infected, that they be discharged to one of two places. One is something we're calling an alternative care center. These are group settings, for instance, a shelter, or in Seattle, what they did was open up a warehouse and set it up like a shelter, which has both shelter services, meaning food, beds, hygiene facilities, as well as medical care. In order for these to be worked, they need to be staffed by medical providers who are able to meet the needs of the people who are infected, who could, once they're infected, be held in congregate settings with one another. For people who are infected or under investigation, they also could go to motels, hotels, or trailers. We recommend strongly that people under investigation not be sent to congregate living facilities with people who are infected, nor should they be sent to congregate living facilities where people are assumed to be uninfected. And so they really need to be sent to a separate facility. These motels, hotels, and trailers need to have some level of medical intervention. And I would love to talk with you about some model programs that have been set up, for instance, in Oakland, that have opened up these facilities in collaboration with members of the health system. If you're interested, you can also look at the right side of the graph of the chart, which recommends protocols for people who are sheltered or unsheltered. I will say that this requires syndromic surveillance, with the caveats that as we learn more and more, there are increasing suggestions that syndromic surveillance may not be sufficient in this population, because we may be seeing many people who are infected yet not showing symptoms. Next slide. For those with evident infections who don't meet criteria, many jurisdictions, including California, have been recommending the use of hotel rooms staffed by medical personnel, homeless service staff, and staffed on harm reduction principles. In Alameda County, in Oakland, they opened up the first of these. They have 2 hotels that the county secured next door to one another. One hotel is for seniors at high risk of infection, and I'll talk about them in the next slide. But the other hotel is for people either under investigation or who have the infection. These individuals can be referred from any healthcare facility or from shelters or homelessness outreach. Once they get to the site is staffed 12 hours a day from nursing staff from Alameda Health System. There they are, if they have not already been tested for COVID with swabs, as well as taken through some basic screening, including things like alcohol use, opioid use, and the like. Everyone who smokes is being offered a smoking cessation patch, but they have also made the possibility available for people to take smoke breaks, where they are escorted out of the shelter to a secure place one by one where they can smoke without causing risk of infection to others. They are offered opioid replacement therapy if they have opioid dependence, and they are working hard to enact safe harm reduction experiences to reduce the risk of people ODing behind closed doors. They are also screened for alcohol use, and people who are deemed to be at risk of alcohol withdrawal are being treated by a protocol developed by a pharmacist from Alameda Health System and a nurse scientist who works in our center, who have developed a protocol to be used where people are actually given alcohol. The state of California has allowed the nonprofit running this hotel to purchase alcohol, and people are brought alcohol at an amount determined by the protocol to their door each day to avoid them going into alcohol withdrawal. This is a term of alcohol management, which has been widely used in supportive housing and shelters in the rest of the world, but has never been used effectively in the United States, and this is being piloted now. Alternative care facilities, as I've mentioned, are like they did in Seattle and like they're doing at the Respite Center in Boston, where they have a congregate living facility with medical staff to treat people who are infected. Next slide. The other similar, this is for people who are symptoms or exposed to a known contact or being brought into these isolation unit. And again, this is a group that actually needs to be kept separate from everybody else, both contacts of known exposures and people with symptoms. Finally, for those who are uninfected, we are recommending that, that these units be prioritized for older adults or those with underlying health conditions like pulmonary disease, heart disease, diabetes, immunosuppressive conditions, cancer, end-stage renal disease, as a population who is most likely to experience the severe consequences of COVID. So we are recommending that as hotel rooms go online, people who are at advanced age, 60 and older, or people with these conditions be prioritized first for the hotel rooms, in the idea that you can reduce the risk of exposure for the population who's most likely to experience negative consequences and require hospitalization. Doing so, removing these people from both the shelter and the unsheltered population presents the opportunity to social distance those who remain in these settings, because we estimate that about a third of the population will be removed from those settings. Obviously, in an ideal world, we would have hotels for everybody. I can say that the state of Connecticut has successfully moved almost everybody out of their sheltered and unsheltered settings into hotel rooms in an effort to reduce spread in that population. Next slide. As Mary Ellen mentioned, there are different funding pots for these, including FEMA. The state of California has negotiated a 75% reimbursement for people who meet the criteria, either being infected, under investigation, or people who are older or have an underlying health condition. And the state and counties are coming up with the other 25%. The most recent federal stimulus included ESG money and other money that can be used for shelters and emergency procedures related to this. States like California have put money up to do this, as well as philanthropy is another setting. The health system really has a role of supplying both medical expertise, coordination, medical staffing, and I would argue a key role in advocacy. I think it is in all of our self-interest to advocate for these isolation and quarantine units and for the ability to lead to social distancing for this population, because they're at such high risk of disproportionate impact. Next slide. In terms of the role of hospitals and health systems, I can't emphasize enough how important it is that we enact a comprehensive screening for homelessness, that we refer high-risk patients. Most places like Alameda that are putting in the ability to bring in older adults or those with health conditions are relying on the healthcare system to identify who might meet criteria based on their health conditions. I think we have a role in advocacy, in advocating for the use of hotel rooms and other similar facilities, as well as a need for us to be explaining why this population is at risk. And finally, we should be working with our partners to create seamless referral pathways, potentially to be permitting our healthcare workers to work in these organizations in partnership with homeless service organizations. Next slide. I just wanted to end just to remind everyone that while we have no perfect screen for homelessness, there are two widely used screening tools that you may be aware of that can be incorporated into electronic health records. The two most widely used tools are the Prepare tool, which is a three-question tool that tries to assess homelessness, and the next slide concludes the other tool. Next slide is the Accountable Health Communities Health-Related Social Needs Screening Tool, which asks similar questions, has more of a focus on health risks in those things. I really think this is the time, if your organization has not done this, to incorporate homelessness screening because of the incredible risk of sending infected people back to congregate shelters. And with that, I will turn, we can do next slide, has my contact information, as well as I would like to turn it back to Jennifer. Thank you.
Margot, thank you so much for taking the time to present to us and share with us not only the experience that you've seen at your hospital, but what you're seeing across the country and specific strategies that you helped to develop. Thank you both to both of our speakers, Mary Ellen and Margot, today. We're very fortunate to have 20 more minutes with them, and we'd like to use this time, next slide please, and for discussion. We want to hear from you. We'd like for you to share your experiences and to ask questions of our speakers. Vanessa, would you please guide us through how to do that process?
Thank you, Jennifer. And now it's time for the Q&A portion of today's webinar. If you have a question, use the raise your hand function to let me know to unmute your line and announce you so you may ask your question. We do have one question already from Margot. Question is, how are you addressing disparities in screening, treatment, or mortality rates among the homeless? What about by race or income?
All right. That is a great question. I think we are extremely concerned, and we've been concerned since before this pandemic hit and are increasingly concerned now that while people say that a virus is equal opportunity, we all know that viruses and all health matters act in conjunction with the underlying structural conditions, and therefore it's no surprise at all, although it's very disheartening to see that structural racism has led to a disproportionate impact of the COVID infection on people from minoritized populations, in part largely because these populations who have experienced the effects of structural racism, that has led to an increased risk of being frontline providers, so increased risk of doing the types of jobs that are low paid but risky and currently working, and are likely to live in crowded conditions if they're housed or to be homeless. We are advocating that all data, and San Francisco has just made this happen, that we release all data by with race and ethnicity, and I think it's extremely important that we advocate for that. I always point out that homelessness itself disproportionately affects racial minorities, with African Americans at a 3 to 4 times increased risk of homelessness, and Native Americans at about an 8-fold increased risk of homelessness. Latinx populations are often not counted in the homeless population because homelessness in that community perhaps acts differently and is often more seen as extraordinarily overcrowded housing, but is clearly disproportionately impacted by these crowded housing conditions and homelessness. So we are basically have made all of our data available based on race, and we are closely following this and trying to raise up the notion and trying to push back against the notion that the virus is equal opportunity. Of course it isn't, and of course your structural conditions are going to be seen and held disproportionately by people who have been really victimized by structural racism, and that those are minoritized populations.
Great, thank you, Margot. We actually have another question here for you. This one is, community partnerships take time to build. How are you effectively building capacity with new partners and expanding capacity with previous partners quickly to care for the homeless?
Right. That is a great question, and partly I would say it's obviously hard to do this in a pandemic, particularly as hospitals are so incredibly busy. And it is when we get to the other side of it is a constant reminder of why we should be doing this at all times. On the other hand, I have seen absolutely amazing partnerships happen nearly overnight. I think really a great example of this is what's going on with Alameda Health System and community partners in Oakland, including a strong nonprofit called Abode, which is one of the major providers of supportive housing and homeless services in the county, and others, where they very quickly realized that they needed to work together. And Alameda Health System has made these medical providers available to partner with Abode to ensure success. And I want to point out that success here, making these isolation and quarantine systems work really demands more than simply caring for COVID. I can't emphasize enough how much taking into account a population that has been deeply traumatized, and because of that experience of high rates of behavioral health conditions and mistrust with the health system needs to be taken into account. And so some of the ways that Alameda Health System has really partnered effectively is by providing providing access to things like smoking cessation, opioid replacement, and management of alcohol withdrawal. I think that really over the course of a weekend, they started to meet together, and these happened very quickly. I think this is another example where a lot of the frustrating things that are often slow, someone comes up with an idea and then they sort of don't publicize it. Everyone is trying to really spread information as quickly as they can. So for instance, the protocols that Dr. Smith-Bernardine, who's a nurse, and the wonderful pharmacist from Alameda Health System, Seth, who she worked with, they are making that protocol available as widely as they can. I think this is a question of everybody knows it's in their self-interest to partner, and we just need to break down those silos and do it. I will say that it is difficult to do quickly, and systems are doing it better who had pre-existing relationships. But if your system did not have a pre-existing relationship, I think your local health department can be a good intermediary to sort of bring people together. But even if you did not have a pre-existing relationship, now is the time to build those relationships.
Thank you, Margot. Just a reminder to attendees on the line, if you have a question, please use the raise your hand function, which is located on the bottom of your screen with the little hand icon. Once you do that, I will unmute your line and then we will announce you and you may ask your question. We also have here another question here for Mary Ellen. This one is, do we expect additional guidance or policies coming from the federal government to address homeless patient populations?
Sure, thanks. I think there's a couple things that go into that. One being we are seeing continuous updates to the guidance coming out of CDC, generally speaking, in terms of infection control across settings. And so we would likely see that those updates would apply to shelters, for example, the same that they would for other care settings. We have seen that HUD has also indicated that they would have further guidance for shelters specifically moving forward as we're seeing more community spread of the virus. The other kind of aspect of this is, of course, the funding side of it is continuously changing. Just today, HHS awarded $1.3 billion to nearly 1,400 health centers, and that's administered through the Health Resources and Services Administration, or HRSA. A lot of those health centers are working with shelters and clinics to provide care to the homeless population. So in terms of making sure that funding stream is available, I think is something that we'll look to moving forward as well. But if Margot has anything else to add on that, I'd welcome your thoughts.
No, I think that covers it. I think that there are a few organizations, by the way, that are trying to push out information on these opportunities. The National Low Income Housing Coalition is doing a really good job both advocating but also messaging. National Alliance to End Homelessness as well as HUD and CDC. I think that these are really good resources to look for if you're looking for updates on what is a very fast-moving situation.
Great, thank you. We have another question, and this one is for Margot. How have you gone about training people, clinicians, shelter staff to use this protocol?
Great question. I think in general, and I should say that I myself am more explaining it to people and others are doing the training. I think that in most places there has been a physician or nurse from the health department who has been put in charge of this. So, you know, what I think I didn't talk about a lot is that the places that are doing this effectively have a sort of a coordinating center, have a phone number that can be called to reach a nurse. Generally has been a nurse who is assisting with symptom screening. We are trying to train shelters to do the syndromic screening. I will say that a barrier has been the lack of access to thermometers, believe it or not, although there are questions being raised about whether temperature is useful. But what we've been asking people to do is to ask these questions and then to call in questions or people who they're unsure about to a healthcare provider. I think it's a little much to ask shelter providers to make medical judgments. So what we've been recommending is that there be a call center or a place where people can call. So if a shelter provider or a homeless outreach person has a question, they can reach someone by phone and have that person do telephone screening, get on the phone with the patient. I do think that we've been asking shelters and training shelters on how to ask the basic questions, training them on things like social distancing as much as possible, when to mask someone, but we've really been asking, having them have a place to call into, to call for help as soon as they need it. I think they are doing a Herculean job, but asking them to become healthcare providers is probably not working that well. In terms of getting the information out as these protocols have been developed, they have been sort of every means possible. Most counties will have sort of either their Department of Social Services or have some other coordinating agency that has a way to get messages out to all the disparate homeless service organizations, and we've been relying on those as well as social media, et cetera, to make everybody aware.
Great. Thank you, Margot. We also have another question here for you. This one says, what happens at the end of this crisis? How do you undo this great work of reopening shelters, etc.?
Now that is a really important question, and I think it has two answers. One is, one thing that I've learned from homelessness is that one can never just focus on the people who are homeless at a given time. And some of my thoughts right now are a very serious concern that the economic disruptions of this crisis are going to lead to huge increases in homelessness. So that's one question. But I think at least I can speak for the state of California. They are actually working hard to not send people who have been put, for instance, if we're hoping to get up to 50,000 people into hotels of our current population of about 150,000 who are homeless. We're actually working hard now to develop plans so that those individuals can be transitioned to housing. A few ways that they're doing it is, for instance, they are using the FEMA money for the emergency response right now and trying to save the ESG money or the emergency shelter grants and other things that are coming through the last federal stimulus package to look for ways to move people from these hotels into permanence. California is actually trying to buy many of the hotels that they have leased. And so they are actually in negotiations with some hotel owners to actually purchase them and convert them into permanent housing. They're also, for instance, I keep coming back to Oakland, but I just think it's such an exemplary program. They have staffed their hotels for seniors who need less medical care because they're not currently infected, with housing navigators, with people who are going to be able to use some of these new federal resources that are coming down the pike to transition people from there to permanence. And they are telling the seniors who are being admitted to these hotels that they can stay in them until they find them housing. I think that we will still be swimming upstream because I think even if we house all of these individuals, I really fear that we're going to see lots of new homelessness coming, and that's why there's huge advocacy efforts now to try to come up with support, homelessness prevention. But I do think that this presents as much of a tragedy as it is, and it is a tragedy, and as much of a crisis as it is, we would be really remiss to sort of not take advantage of this crisis to move people into housing as we move forward from here. We really know how to house people. We know what housing first policies work, and I think what they are hoping is that we can use this moment to get people access to what they need to leave these hotels, either to permanent housing, whether that be by the widespread purchase of these hotels and retrofitting them into housing units, or whether it be just working with people to use the principles that we have known before, including rapid rehousing and permanent supportive housing, to transition people from the hotels into permanent housing.
All right. Thank you so much, Margot. And now that looks like all the time we have today for questions. We wanted to thank you all for joining us on the webinar today. And we hope you'll join us for a future webinar in this COVID-19 series on Wednesdays at 2 p.m. and encourage you to access the resources on our website. And that we will conclude today's webinar. So please keep an eye out for an email from us tomorrow that will contain a link to a brief evaluation form. Please share your thoughts, which can help us to ensure our webinars best meet your needs. The email will also contain a link to a page with a recording of and materials from today's webcast. Thank you again to our speakers and to our audience. Enjoy the rest of your day. Goodbye.